emergency. So I'm going to give you some quick data points because I want them in the to set the context for today, and then I'm going to turn it over to Luann. So if we can put the PowerPoint right back up for me to do that, I would appreciate that. So mental health, and I'm not seeing the PowerPoint for some reason. I don't know why. Is it me? Okay, there it is. This is just, you know, as Chief said, Tier 3 day, we talked about it on day one. We went through our universal supports, which should support and help about 80% of our students to be able to build the skills and teach them emotional regulation, coping, and build relationships, because we know relationships are the most important thing. But we also know that during COVID and even before COVID, 1 in 5 students were school-age children were having challenges with mental health, emotional health, developmental or behavioral disorders. Now, this is from the Surgeon General. You might remember that the Surgeon General did put out a report in 2021, elevating the crisis in children's mental health and talking about how the pandemic added to those pre-existing challenges. So they were there before the pandemic, but they have increased in our children and our adolescents. So also, we were talking yesterday, I heard many of the questions, you know, why is this happening? The Surgeon General did put some things out around the, you know, we didn't have in-person schooling for a while, the social opportunities with peers and mentors, access to many of the services that are out there, social services, healthcare. We know that there was a lot of food and still is food insecurity and housing insecurity, and there's often a workforce shortage to access those services and supports. On the next slide. Also, I recently heard a report, another new report about loneliness. That's been talked about at the summit. There's just an increase in loneliness in our society. Adults, veterans, our students, teachers. For some reason, our relationships is something that we can really think about as we go through the summit. All of you on here are the passionate people that help make those relationships happen in schools. These 2 data charts are pretty powerful, so I want them in the deck. From our State Department of Health Services does the Youth Risk Behavior Survey every year, and that's through the CDC. And on that first chart, you can see the 10-year trend of the rise in hopelessness and sadness that our students are reporting. And look at that quick uptick right there. So that's an important feature, because it's hope that gets us through those hard times. And if our students are losing hope, oftentimes then look at the next slide. Students who are committing suicide were trending up. On this slide right here, you can see the emergency room visits, how they increased during the pandemic. The dotted line there, they went up significantly for our children and our youth right away when the pandemic hit. 24% for 5 to 11, 31% for 12 to 17 age children. So something to consider that families were dealing with. Next slide. Now, we didn't get to do the whole survey. CDC did an additional survey during the pandemic year, during 2021. So this is where 37% of our youth experienced poor mental health during COVID-19. And the uptick in the sadness and hopelessness, 44%. In Texas, that's about a 10% uptick in students feeling sad and hopeless. And this is something I really want us to keep in mind, because I think these are trends that you in schools and us in the community can all work with together. Next slide. Here's another slide that shows the youth who seriously committed suicide considered committing suicide over the past 12 months or attempting. Here it is by sex. We did some talking. I know that there was a rise in males in Texas. We have also seen a rise in females. So you can see the data trends continuing to go up. I think this was very important, because I think one of the most important things that we can do is work with our parents. I heard some wonderful things from communities and schools and others in terms of reaching out to parents, to educate parents and connect to them, since 31% of our parents shared that their emotional health of their child deteriorated during the pandemic. So please consider those parent opportunities, engagement, workshops, all of that we can do after school, during school. virtually and in person. Next slide. I'm glad that this slide is in here because this shows some things that we can do. Remember that students who continue to feel connected to their schools during the pandemic experience less deterioration in their mental health. So we know school connectedness, that's where relationships can really happen with peers and adults, was important. And so we want to keep that connection to the school. And then that creating of a calm and safe and predictable environment can help children regulate their emotions and be ready to learn. We talked on day one about the school-wide, the universal supports, PBIS, positive youth development, all the things that we can do with our counseling programs and others in our schools. We know that those strong relationships with caring adults matter, and that research goes back very far. And so if a student has even one a relationship with an adult in a school building, 2 is even better, but that can really, really matter. And we heard from some of the school leaders how if we don't know who a student is, suddenly they might be an internalizer. We don't know, but bad things can happen. So if we can double down on making sure all of our students have relationships with caring adults, that's something we can do. And trained educators can help identify mental health concerns early, leading to more rapid improvement and further negative impacts. We heard from HHSC about the mental health first aid program and other different programs that we heard about from CIS and other presenters about equipping our educators so that they're able to make a referral pathway, however it's set up in a school, to get some more help for our students. So we need to equip our educators. And I've also we've heard from some universities even here, working on strengthening teacher educator prep programs inside universities or teacher prep programs. ESCs are helping with this a lot to make sure educators are more ready for what they're going to see when they walk into the classroom. And finally, this is important that students on that on that last point, I'm just going to say that students who do receive treatment, most students who receive tier 3 treatment or that intensive help, intensive support, often from a non-physician mental health provider, they're going to receive it if it was made by a connection from the school. So schools are important either for school-based mental health services or making the connection and the partnership happen to the community-based provider. And that's why you heard a lot through this summit about case management services, social work services, coordination through the school counselor, through student support services teams who can help build those relationships, memoranda understanding, referral pathways with community providers. And then we can also bring community providers into the school to provide those services. And this is just a beautiful picture when we engage our volunteers in our schools, when we build those relationships and we look at the school as a central part of the community that's not isolated, but connected to our community. We can help our students build many more relationships. And if then a tier 3 service is needed with mental health professionals, we're ready in advance because we've built those partnerships and we've spent that time, invested that time building those relationships. And that's why I'm turning it over to Luann Southern right now. Luann Southern is the executive director of our Texas Child Mental Health Care Consortium. And I am so proud to be able to turn you over to Luann because she's an amazing human and is just leading some amazing programs in our state. So Luann, I am about 1 minute over, but I am turning it over to you now to give us the first panel. Thank you.
Thank you so much, Julie. That was a very kind introduction. And welcome everybody to the ABC Summit Day 3. We're glad you're here. I'm so glad that Julie provided that intro to some of the big picture issues that I know all of us are addressing as we're out in the fields of children's mental health and also in the education system. I'm very excited about the panel that is going to be providing information to you this morning. We're going to start with Jeff Carr. I saw Jeff a couple months ago. Hi, Jeff. Out at Texas Tech University in Lubbock, and he started talking about some of the really cool things going on at Texas Tech in terms of outreach and engagement. Jeff is part of Texas Tech's team that provides our Texas Child Mental Health Care Consortium initiatives, including the Texas Child Health Access through Telemedicine, which many of you know as the acronym TCHAT. We also have with us Dorothy Garza. Many of you probably know Dorothy. She's been around for a long time. Dorothy's going to talk about what's happening now that she's back in Central Texas doing work on the ground through communities and schools. So happy to have her here. And then we have Tanisha Kennard from JPS Health Network up in the Fort Worth area. So we have Central Texas, North Texas, and West Texas represented today. Tanisha has been involved in JPS through working with University of North Texas, also to provide services through the Texas Child Mental Health Care Consortium. Each one of these three individuals, I'm so excited to have them with us today. They bring a wealth of experience, not only in mental health, also in education, and in working directly with communities. So I'm going to turn it over to Jeff, and I can't wait to hear what y'all are going to talk to us about today.
All right. Good morning, everybody. How's everybody doing? So I'm really pleased to be here today and appreciate the opportunity to talk with all of you about the kind of programs that we are bringing to our general area in our region that I'll talk about here in just a second. And so I'm the Senior Program Director of our Education and Outreach Division at Texas Tech University Health Sciences Center, which is to be considered the prevention arm of our Cater Supported by TCHAT program. And you'll see here all of the Mental Health Care Consortium programs that we operate through CPAN, the Child Psychiatry Access Network, as well as our perinatal mental health program. So my division assists with providing all of the education and learning opportunities for all of these programs. But I'm going to talk today about the school-based program and what we do regarding our school-based services. And so just to give you some context, our coverage area right now is 85 counties wide. It covers the majority of some of our 6 education service centers and then all of several of our education service centers, as you can see here. And just to note that our coverage area is geographically very large, and it covers about 34% of the state of Texas geographically, and all of it is a very, very rural area. And if you've ever been to West Texas, then you'll understand that. And some of our North Texas areas where Wichita Falls is, it's a very rural area. And so to give you a little bit of context about the history of where we're coming from, back in 2013, Texas Tech University Health Sciences Center already had an existing school-based mental health program that was created to go in and provide mental health supports, interventions, and assessments via telemedicine, telepsychiatry, and telecounseling in those school systems. But we were only in about 10 to 25 of those independent school districts at that time. And then so being funded through state funding for about 4 to 5 years, the project was renamed to Cater for a number of different reasons, but we renamed to Cater but kept the same model in place where we were going into schools and providing those mental health supports via telemedicine and telepsychiatry. And with the onset of COVID and with some changes and some pivots in our programming, we went to go completely virtual with our assessments and all of our programming. And then when TCHAT came on from the Texas Children's Mental Health Care Consortium, we expanded our program, which allowed us to move into these other independent school districts and cover this very large region, which is why you'll hear us referred to as Cater Supported by TCHAT, because we had that existing funding through Cater. And the reason I mention that is because the way we're able to do things at Texas Tech University Health Sciences Center is going to be a little bit different than what you find at the majority of the other health-related institutions across the state of Texas, because my division is funded solely through that existing funding back that started in 2013, not necessarily with these TCHAT funds. And so we have the capacity to do some things that maybe some other regions do not. And so to give you an idea about our coverage, if we'll go to the next slide, and I apologize that the dates for this say through September 30th, and it's actually through November 30th. And just since submitting these slides, these numbers have changed already. So we're now technically in 162 school districts, which means our total schools and covered lives have increased significantly as well. And so just to give some context about what we are covering, our entire region, as far as our school districts, is not entirely enrolled yet, but of our school districts, 161 or 162 are currently enrolled. As far as my team is concerned, on that next slide, my team is made up of people with education backgrounds and mental health backgrounds and project management backgrounds. And so there are 8 of us housed here in Lubbock on the T2HSC campus. And then I have 4 housed on the Abilene T2HSC campus and 2 at Midwestern State University. And just briefly as my team structure on that next slide, you'll see that we are employing people to work in certain sectors. And so we have an adolescent substance use disorder coordinator that helps with the education for adolescent substance use. We have a coordinator for our virtual education, which we'll talk about in a minute, and then a program manager, for all of our in-person education, which includes our YAM that we will talk about and all of our in-person training we talk about as well. And so to move forward with what learning opportunities we currently provide, we have some consistent weekly structured activities we're providing through T2HSC to our regional schools. And that first one that I want to talk about is called Project Echo. And if you're unfamiliar, Project Echo was started out of the University of New Mexico to try and combat the issue of liver disease. Dr. Sanjeev Arora out of the University of New Mexico was the liver disease specialist in the area. And he had patients traveling hundreds of miles, days at a time, taking time off of work in order to come in for their treatment because their providers of care in their home communities were unable to provide that specialist level of care. What was happening, though, is that over the course of time, the wait list became so high that he was actually having patients not receive the care that they needed or actually pass away before they could receive all of the care that they needed. And of course, like all of us, we would say that that was kind of an unacceptable thing to him. And so he developed Project Echo, where he disseminates information, education, and training to those providers in those communities via a tele-echo platform, just like you're on today via Zoom. He provides that education and training to them online so they don't have to travel, but it keeps that training and keeps that care in the medical home. They can see their patients without having those long wait times and long drive times. We took that same model and applied it to an educational setting for school-based behavioral health. And so our Echo for School Behavioral Health happens every Tuesday morning from 9 a.m. to 10 a.m. And we cover a number of topics, and I'll talk a little bit about Echo here in just a second, but we cover topics that are professional development in nature. They're evidence-based, but what makes Echo different from a webinar or going to a professional development somewhere is that Echo combines case-based learning into the platform. Case-based learning meaning that school counselors can submit ahead of time actual cases about student struggles on their campuses. And they can talk about, I have a 12-year-old female who is in this grade struggling with the following. This is the home life. This is what's happening at school. This is what we are seeing. And this is what we've done, but we're having trouble getting her connected with her peers. We're having trouble with decreasing her anxiety or the depression, whatever is happening. So what these cases allow is for those counselors to come in, present this information, and then they receive feedback from our subject matter experts in everything from counseling, psychology, community mental health, school mental health, psychiatry, and they can provide feedback that's evidence-based and can be utilized in a school-based setting. But another portion of that is that these presenters of these cases get peer feedback from their peers that are on these sessions from other school districts who say, I've had students just like that. We implemented this and it was very, very helpful. And so they receive peer feedback and expert feedback at the same time. Another thing that we noticed is that we're seeing higher rates of vicarious trauma, compassion fatigue, and burnout from educators on all levels. And we were hearing from administrators that they appreciate all of the professional development that we're providing to them, but they needed supports for their staff just to feel like they are supported, that they're emotionally well, and that they are taking care of themselves. So we developed what are called counseling connections. So every Thursday from 1 p.m. to 2 p.m., we have these virtual sessions that are guided discussions from our licensed mental health clinicians on self-care focused topics. And we'll talk about that in a second as well. And then we also work directly with education service centers to provide not just professional development, but to provide information and speakers and to connect schools with their education service centers to provide content to them and get the information that they need. So on our next slide, I'm going to talk specifically, like I said, ECHO, that Extension for Community Healthcare Outcomes, was designed to democratize knowledge and also reduce variations in care. So not only are we trying to increase mental health awareness, we're also trying to increase the confidence that staff have in providing mental health to their students in their settings. And so through our ECHOs, just in this academic year alone, of the few sessions we've had since September, 88% of our evaluation respondents report that they feel better prepared to provide mental health care to their students as a result of participating in our ECHO sessions. The other 12% say they just feel no less or no more. And so what we know is that no one has said that they feel less prepared. So we haven't broken anybody yet. So we're real happy with that. And so on our next slide, we're going to talk very specifically about that process. And so that case presentation process is going to be like referring a student to a program. And so they identify that particular student in grades pre-K through 12th grade that are a part of that ISD. The counselor is going to fill out that case presentation request form that gives us all of that information. We send back to them that request form in one of our forms. We schedule the ECHO session with them. They come on the session and they present the information. They receive that feedback. And then afterwards, so that they don't have to feel like they have to write madly to take notes on what were those suggestions, what were the resources and the considerations, we provide all of that to them, back to them in a case considerations and resources form. And then we try to schedule a follow-up case presentation with those counselors several months down the road to kind of see where the progress is regarding that particular student. All of this, we don't collect any protected health information. So what it means is it falls directly under consultation. So school counselors and school staff don't have to worry about parental consent because we never know who the student is. We just hear about the student's struggle, and then they get feedback that is evidence-based and can be put into a school-based setting. So next, I want to talk about the customized content that we provide. And this was something that is somewhat new as our program. We've been providing those ECHO sessions since January of 2020. And so we're going on our third year here pretty soon. Just within the last year to year and a half, we received a lot of requests from schools saying, we are kind of over meeting virtually. We really want to see some faces. We want to shake some hands. We want some side hugs. You know, we want to actually see some people. So will you come and talk with our staff in person and train them on things like you see here, our sample workshops on anxiety, depression, self-care, bullying behaviors, vaping prevention, mental health awareness, suicide and non-suicidal self-injury. And that's just a sampling of some of the content we can provide. If it fits in that broad spectrum of complex mental health, then we can create the content if we don't already have it. Our most popular option is that they ask us to come on their professional development days or during specific days. And we've done everything from 1-hour presentations to staff on all levels, or we've done as much as multiple day trainings for multiple grade levels for those particular school staff. We also provide that same level of workshops and training to students and to parents on a more developmentally appropriate level, of course, for things like mental health literacy, peer support, and help-seeking behaviors on topics just like what we provide to schools. But it may just look different depending on the developmental level. And then when we move forward to our next slide. So our counseling connections, like I mentioned before, those are those self-care focused guided discussions with our staff. And some of those topics that we've provided to them include things like educator fatigue, virtual mindfulness, recess for adults, coping versus self-care, teacher loneliness and isolation, as well as positive psychology and relaxation. And we build those out every single Thursday from 1 p.m. to 2 p.m. The only exceptions being on those holidays that school districts are out of school, we don't provide those, but we do provide it throughout the entire summer. And that includes our ECHO sessions as well. So we do summer programming for all levels of staff as well. One of the last things that I wanted to talk with you about regarding an actual program that we provide directly to students, you might start hearing about more, especially through TEA or through school districts or through local health-related institutions, is our Youth Aware of Mental Health program. YAM is a TEA-approved evidence-based program. It's a free 5-session program that promotes mental health literacy, help-seeking behaviors, It works on for emotional intelligence and suicide prevention and intervention. It's evidence-based for 13 through 17-year-olds, and we deliver it over 3 to 5 weeks. Our certified YAM instructors deliver this content on your campus to students in a specific grade. And so we bring this directly to all of your 9th graders or all of your 8th graders, or for some campuses, it's all of your 8th through 12th graders receive this specific TEA approved curriculum for youth mental health, and it's going to supplement your existing programs. And so what we don't want to do is come in and supplant other programs. Instead, we prefer to come in, and what we want to do is provide an opportunity to enhance the programming that schools are already doing. Most schools are already addressing mental health on a number of different levels, and what we want to do is come in and reinforce what schools are already doing, but add more tools to the toolbox for students, staff, and for parents alike. And we're trying to bridge those gaps. And so this YAM program is a unique way to do that because it's a little more student-led. Our facilitators lead the discussions, but students take the conversations in the directions that they want. And so we're really happy to provide this to our schools free of charge. So we provide all of the posters, we provide all of the booklets, all of the travel for our certified YAM instructors, and the training and everything is 100% free to schools, as well as we have an option for schools to send their own staff to be trained to deliver this in their schools so that we can continue to sustain this program well into the future. So on our next slide, I just wanted to kind of briefly go over the fact that this is a collaboration with the Risk and Resilience Network at the UT Southwestern Center for Depression Research and Clinical Care. And what you're going to find is there are actually 6 or 7 different health-related institutions across the state of Texas who are delivering YAM. So much like TCHAT is a statewide program, YAM is not fully statewide yet, but it's being piloted, for example, in 7 of the institutions, and Texas Tech University Health Science Center is one of those. And so we're trying to create a culture of mental health within schools in which they are able to talk about mental health without feeling ashamed of mental health. Kind of this idea that it's okay to not be okay, but it's not okay to stay that way. And so talking about it is the first step. And this is what we do in YAM, is provide an open opportunity for students to talk about mental health the way that they understand it, and then provide them with supports and connections to meaningful adult relationships and community resources that are going to be beneficial for them and their families and their peers. And then lastly, I just wanted to give kind of an overview of what we have done just since the inception of this Education and Outreach Services division that kind of began back in January of 2020. So since then, we've completed 89 Cater TCHAT Echo sessions, and those are those sessions for those school-based staff. So 89 different sessions. We've completed 14 professional workshops, meaning we introduced these back in 2021 when schools asked us to come do these, and we started doing those in 2021, and we've done 14 of those on varying levels. We've worked with all 6 of our education service centers, and we've done 34 of those presentations in their safety summits, in their professional development opportunities, and in their trainings. As far as that Youth Aware of Mental Health program is concerned, we've completed 49 of those trainings, which means one specific training is all 5 sessions. So we've done 49 cohorts with well over 800 students at this point in time. And then we've done 14 student workshops over the course of the past 2 years. And I wanted to give some context to what that means. So when I talked about our West Texas region being very rural and being very geographically large, we have a smaller covered lives, for example, than a Houston or a San Antonio or Dallas, but our geographical region is larger, which means all of our staff have to travel further to go to these locations, in which we have individuals from Abilene traveling all the way up to the Panhandle, people from Lubbock traveling to Wichita Falls traveling to San Angelo. So what we have done over the last, and this realistically is over the last year, is we've traveled almost 22,000 miles delivering these educational content. And for a fun little bit of context, to circle the entire Earth just once is 24,901 miles. So at the end of this academic year, we will have, for lack of a better description, we will have traveled the circumference of the earth at least once in order to deliver these educational activities. But we're really happy to be able to do them, because when we can increase mental health literacy for these staff, students, and parents, we also create some pipelines for them to, some pathways for referrals into TCHAT and into CPAN and some of the other programs that you're going to hear about. Well, that's what I have for you guys today. I appreciate it. Thank you so much for letting me present this information. I wasn't sure if we were going to take questions now or wait until all of the panelists had gone.
Thank you so much, Jeff. This is Lou. Hi. Thank you so much, Jeff. We're going to take Q&A after everyone is finished. We've got some questions already in the queue, and I really appreciate your presentation. I just think it's wonderful what you're doing to support educators in your 85 county region across West Texas. So thank you so much. Next, we're going to hear from Dorothy Garza. Dorothy is a wonderful person, and I can't wait to hear what she has to say about what she's doing in the Central Texas area through communities and schools. I'll kick it off to you, Dorothy.
Thank you, Luann. And thank you, Jeff, for going first. That was super helpful to kind of get a pacing for the slides and whatnot. I also took notes on many of the things that you just presented. So again, thank you, everyone. I'm honored to be a panelist for with the ABC Summit. I was on the other side of things last year and learned about the summit firsthand then. My name is Dorothy Garza. I am the Senior Director of Mental Health Services with Communities and Schools of Central Texas. And I've been with CIS Central Texas just shy of 6 months. This is my third iteration with Communities and Schools. At that time, it was of Austin, and now Central Texas. I started as a graduate intern quite a few years ago. A little later down the road, became a program manager, left, and now I'm back again in this role. So as I thought about this presentation, I thought, maybe people might wonder, why keep coming back to CIS? And so I wanted to kind of frame my presentation from that perspective and what we are doing through some initiatives in the vision of CIS Central Texas now. So I'm going to give a brief overview of CIS's mission. I know that many of you may be very familiar with Communities and Schools, already having some partnerships within the schools. Some may have be somewhat familiar with CIS, but not have it in their communities. And for some, this may be new information. So if it's a review, please bear with me, but we'll get down to the efforts and new activities that we're doing here in Central Texas. So if we could go to our next slide. Perfect, thank you. So Communities and Schools is a national program. It was started in the 70s, and I think there are 23 states that have affiliates now. And in Texas, there are 27 affiliates based on the most recent research data that I found. And so that means about 150 school districts, give or take. All of the CIS affiliates share a common mission, and that is to surround students with a community of support, empowering students to stay in school. And I'm going to read this because it's just so important, to stay in school and achieve in life. And so each program may address this in a slightly different manner to meet the specific needs of their community. And so that underlying foundation, though, covers every CIS affiliate. And then again, like I said, it looks a little bit differently in each community. So if we can go to the next slide, perfect. So CIS Central Texas provides support for students and their families in 103 local campuses in 8 school districts. And so all of those districts are in and around Austin. Pflugerville is our newest school district, and we were fortunate to have, you'll see that it's indicated as My Brother MBK Scholars. That stands for My Brother's Keeper Scholars Program. They are a program serving Pflugerville ISD high schools, and came under the umbrella of CIS over this summer. So we're really excited to now be able to provide them some support. Let's see. Oh, good. I'm seeing chat there. So those are the campuses that we are currently serving. So why this model? So go ahead and you can move. Oh, perfect. You're right where I need you to be. So the idea behind communities and schools is that there is strength in the partnership between what the schools are doing, the teachers and school personnel, and bringing in, partnering with an organization skilled in addressing the challenges that may get in the way of a student, a young person, achieving all that they can, both academically and personally. So it's that idea that if a child is hungry, if a child is worried about something, they're not able to focus completely on what they need to be doing for school or just having friendships. And that's where communities and schools can help complement and supplement what's already happening at the schools. So that's kind of the why. Now I want to talk a little bit about the how. We'll go to the next slide. Perfect. So CIS, as I mentioned, is a national program, and there is a specific model on how the programs look and what are the key components of the program. So if we can go to the next slide. So from the initial design of communities and schools, they've had over 40 years to develop and pivot and edit the way that they approach service delivery and to meet the needs of students that not only impact individual students, but impact the entire campus and that community. And so we are fortunate to be able to utilize those supports and resources and lessons learned within our own local affiliates. So if I can go. So you'll see this infograph. Everyone, it's a unique model in that we again have the national support, the state level support. We also, so we have that support and that uniform foundation. And then we have our on-campus based staff. And so for Central Texas, they're called program managers. Some of the other affiliates may call them site coordinators and a couple other titles, but they all are the same in focus, where they are providing services on campus. And so that is another key component of our program. And then the collaborating with partners is another part. So again, it was that model back in the 70s of saying, hey, let's bring in some other resources into the schools. And again, that was mentioned in other part of the first presentation, is bringing in those community resources. And so for us, our program managers have work with our strategic partnerships team in leveraging those leveraging partnerships. And so where it's appropriate and where it's available, the Central Texas area covers covers Austin, which is, pretty urban and has a fair amount of resources. We also go into some more of our rural areas, though those are kind of a mix, as people are moving out of Austin and into our surrounding school districts. Those are becoming more, having different kinds of needs in addition to some more isolated areas and communities. So it's been, it's very interesting on how we are able to leverage those kinds of resources. So the next part of this wheel is every program is going to address these 6 components, or these 5 components rather, of our planning of our model. And it's really driven by the program manager and their partnership with that school leadership. So a needs assessment is done to make sure that there's a clear picture of what that campus needs. Planning is intentional so that everyone is on board as to what the activities, what those outreaches are going to be, what the partnerships are going to look like. Integrated student supports are the key to what we offer to the school districts. They are offered at a tiered level. So just like a tiered level of services within the educational system, our model also reflects that tiered level of support where we have universal programming. And so it may be a health fair that CIS works on with some student leadership to provide information to the whole school. Then we have our tier 2 targeted services. Those may be groups for different levels of children. And then our more individualized services where we may be doing some mentoring and tutoring and some check-ins related to mental health. So it's going to vary from campus to campus, but all of those levels are going to be represented in each campus. And then we're not just doing services, we are also ongoing, there's a monitoring and adjusting, pivoting as the campus, as different needs may come up, and making sure that those services are meaningful and relevant and benefiting the campus. And then finally, there is evaluation. So we do partner with TEA. Partner is the best word I could come up with. They also provide some governing around program requirements, that kind of thing. But it is really a partnership. We have representation for communities and schools at TEA who offer professional learning collaboratives, and those have been extremely helpful. But getting back to the evaluation, we are entering data into a centralized system, and we're tracking the numbers of services, the number of students being served, outcomes for those students, so that we're ensuring that what we're doing is having that positive impact for students. There is also feedback that's received from the campuses as well. So the CIS model works because it is evidence-based, because there's community, it's not siloed. Programming is individualized, and our staff are highly skilled and trained. We have worked very hard to diversify our workforce to meet a couple of needs. One, our commitment to diversity and equity and inclusion, but also in response to the behavioral health workforce shortage, we have really created some new opportunities and have provided that supplemental training and support needed to make sure that everybody is on a level playing ground. All right, next slide, please. So this particular, I just like the way they all look very committed and engaged, and being on site is powerful because as so many of you know, those partnerships only work when there's trust and communication and understanding of the importance or what the priorities are from both sides. And so being on site is integral. And so those immediate needs can be met. When COVID happened and there was an increase in just basic needs, CIS Central Texas was able to pivot and really strengthen those basic needs supports and come up with a system to get those two families. And so that part of it is super important. We'll go ahead and then next slide. So what my program is, so in thinking about what were the gaps and how could CIS Central Texas help to address some of the gaps, they already knew that mental health was a big need. And so they came up with the idea of the mental health wellness team. The idea was to provide a number of services, but one particular was to add counseling, a short-term intensive counseling program to our highest need students who were struggling to participate in CIS programming. I will say that we received guidance from CIS San Antonio and CIS Houston, and just gracious in sharing of ideas and documents so that we didn't have to reinvent the wheel. So shout out to them really quickly. So our program overall has 3 prongs, if we can go to the next slide. We have the short-term intensive counseling that are provided by clinicians. So we have LCSWs and LPCs who will be providing the counseling to students. We've created a referral process and a rollout plan to our campuses to provide support to campuses in little bits at a time and rotating that support out to different schools. We're also responsible for the internship program, and I'll talk a little bit more about each of these in a little bit. And so we have undergraduate and graduate level students from diverse degree programs, social work, counseling, but also applied sociology and criminal justice. And so I'll talk a little bit more about what that looks like. And then providing training to our agency personnel and eventually our school communities. Like I said, I've been with the program with CIS for 6 months. So we've been blowing and going and getting out our counseling services and the agency mental health trainings, but we will eventually get out into those communities to get that resources available. Okay, next slide. Oh, can I get advanced to the next slide?
Give us just a second.
Sure. There we go. Okay, so again, the counseling is available to our CIS case managed students. And so this is to give the opportunity for that program manager, the campus staff to intervene for the student. But it's when that isn't working that our counseling, we can receive a referral for a student who may benefit from some intensive counseling. The idea is crisis stabilization. It's reintegration after a crisis. And it's definitely with the idea from the initial treatment plan to transition and plan for that transition either back into integrated student supports and or a community mental health resource. This is our pilot year. We are hoping to serve at least 160 students. We are currently targeting 9 campuses at all levels, elementary, middle school, and high schools. And so let's see. Yep, that's okay, great. Thank you. So our internship program also, we have a long history. As I mentioned, I was an intern in '91, and I don't know if I was the first one. I know I was one of the first cohorts for that campus. So there's been a long history with CIS supporting the professional development through practical experience for our students, for our university students. We have students from our local universities, UT, Texas State, St. Edwards, but we also have students from UT Arlington, UT Rio Grande, Our Lady of the Lake, that are online programs. And then students are here, living here, and so they're able to do their internships here. And so that's been really exciting to learn about. Our interns are learning about CIS. They're learning about working with individuals and groups. They are learning to work with families. And I think most importantly, the last 2 points on this is that they are learning to navigate school systems and work in partnership with schools. So regardless of where they end up, that's already a skill set, and that they are also getting a trauma-informed perspective and having practice within an agency that's committed to diversity, equity, inclusion, and belonging. So that language and they bring that to us as well and question. And so that's always the benefit, I think, of working with interns. All right. So we can't do all of this to everyone, provide the counseling, because we're a team of 4 right now. And so we wanted to be able to provide more services throughout our agency. So we've created some agency mental health trainings and or brought in presenters. These are some of the some of the topics we've addressed. Trauma-informed self-care for the helping professional is coming up. So Jeff, I'm reiterating, like, it's that, and I already wrote down the counseling connections idea. We're going to do that. We are offering field instruction support in the same kind of way with office hours to make sure that our folks that are hosting interns have that ongoing support. We will be doing school community mental health training, partnering with other organizations, including our local mental health authorities, to provide that and extend that out. We're providing peer consultation to our staff who need a sounding board or problem solving around different topics. And we also are piloting offsite supervision of interns for those program managers. Again, it's our commitment to diversifying our workforce, but sometimes we have a program manager who may not have the degree or licensure required from the university. So we have the capacity to provide that clinical supervision to the intern while that program manager provides their task supervision. So that's what we've done to help expand capacity throughout our agency. Whew. So I want to say, and we'll put in the, it's very simple, communitiesandschools.org is the national website. But I wanted to get back real quick to why did I keep coming back? And I think it's summed up in that model of all in for kids. This agency has grown and pivoted to meet the current needs. And I've hoped that when I've left and I've gained other experiences, including my time with HHSC, that I've come back richer and have more information to share and be able to better support that idea of all in for kids. Thank you so much.
Thank you so much, Dorothy. That was wonderful. Thank you so much, Dorothy. I love your enthusiasm about your work, and I'm glad you're back doing what you love at communities and schools. Next, we're going to hear from Tanisha Kennard. I had the opportunity of meeting Tanisha a couple months ago, and we did a site visit up in Fort Worth. So impressed with the work you're doing up there. And through the Texas Child Health Access through Telemedicine and other consortium initiatives, Tanisha works for JPS, and they have this wonderful partnership with the University of North Texas. So I can't wait for everybody to hear what you're doing, Tanisha. Welcome.
Thank you, Luann. Thank you for the opportunity to be here to share with you all at the ABC Summit. This is my first time here with this group, so I'm really excited about the opportunity. I'm going last, which has its benefits. And so I was really excited to hear about the different things going on at Tech and with communities and schools. Those are 2 organizations that have been doing tremendous work. JPS as an organization has joined this effort more recently than those 2 organizations. So we are definitely learning from everybody around us. I want to take a minute to kind of introduce myself. My name is Tanisha Kennard. My role at JPS is Executive Director for our Outpatient Behavioral Health Services. To give you some context for those that are not familiar with JPS Health Network, we are the safety net hospital in Tarrant County. And so traditionally our services are county bound for anyone who's seeking services. JPS has the benefit of having a full continuum of behavioral health care, from a psychiatric emergency center through inpatient psychiatric treatment, all the way to outpatient clinics throughout our county. The opportunity for the consortium projects gave us the ability to expand our behavioral health access to a 9-county catchment, and we were really excited about that. Listening to the context of some of what this group has already discussed, I won't spend a whole lot of time in giving you mental health facts. You guys are living this life. You know what we're seeing each day, but I do want to tell you a couple things to kind of lay the groundwork for how and why JPS and UNT Health Science Center felt that it was so important for us to partner and become part of these projects. In our catchment, which we'll talk about a little bit later, we share one of the most populated counties in Texas, and that's Tarrant County. And one of the things that had been looked at Tarrant County as far back as 2014 was the decrease in the number of mental health professionals, practitioners, and clinicians that were available to provide care, and the ever increasing need. And then we all experienced the pandemic, right? And so COVID hit, and immediately thereafter and during, we saw the impact of isolation. We saw an increased incidence of anxiety and depression. And just in our general clinical services, we saw a massive increase in demand for services, both self-referral and provider referred. As far as our children and adolescent population, Tarrant County has seen suicide rates in that population increase more than 100% since 2006. And so the opportunity to be part of an expansion of care for this particular population was very important to us. It sounds like most of the people here are familiar with the Texas Child Mental Health Care Consortium, but if you're not, bear with me. If you are, and if you're not, I'll give you a couple facts as background. The project was created out of the 86th Texas legislature in 2019. The idea was to create a coordinated effort across the state of Texas to be able to provide mental health services and expand the access to care to children and adolescents across Texas. So eventually, once the project is fully deployed, these services will be available in every district across Texas for all children and adolescents that would need to access them. JPS specifically, next slide, please. JPS specifically partnered with UNT HSC for our projects, and we have created a leadership team, and the people you see on the screen here are primarily responsible. I am the one here talking to you, but there's no way that these projects would get done without the collaboration of our medical director, Dr. Allison, our program manager, who just recently finished her PhD as well, Dr. Siegel, and Mrs. Calhoun, our clinical manager. Next slide, please. As far as program staff, to give you some insight as to how we're built, we have program managers, clinical supervisor, TCHAT program coordinator who does the primary outreach to all the campuses. We started our program in March of 2021. And since then, we have already made contact with every district in our catchment. We cover about 76 districts in our 9-county catchment. We've contacted them all at least twice, and we have about 24 active MOUs. And we'll talk about how many covered lives that is and what that looks like in just a second. We employ, can we go back for just one slide? We employ 7 therapists currently, and we're expanding that. I want to take a minute to explain to you the 2 case managers. When our TCHAT program started, we started clinically focused with mostly therapists to provide the care to the patients. What we quickly realized is that our therapists were spending an enormous amount of time each week in case management activities with the families. The families, in some cases, didn't always need that clinical approach. They really needed case management to partner with them to create a discharge plan and resource finding mission, along with the care that the child or adolescent was receiving. So in our first 6 months, we realized this. We went back and worked with the state to find within our funding to be able to bring on board case managers. And that created an immediate expansion in capacity for our therapists. Our therapists, for each therapist, we were able to increase their workload, their clinical capacity by almost 10 additional visits each week by adding those two case managers, and they have done tremendous work. You will see in this presentation, we'll talk about our show rates, our no-show rates, and how we communicate with families. But one of the integral pieces to the success of our program to this point has been the addition of case managers that connect with that family at the point of referral, and then follow those families through their discharge, connecting to their discharge appointment. And so that has been very helpful for us. Next slide, please. I've seen a couple questions come through about how facilities are funded. Our entire TCHAT effort is funded through the Texas Mental Health Care Consortium. This funding is provided through UNT Health Science Center, who partners with us as the service provider at JPS. So we employ the staff and they provide the care to the patients and manage the cases clinically. UNT Health Science Center and JPS have a long-standing partnership and relationship for multiple projects. So it was ideal to partner with them to also be successful in this endeavor. Next to that information, you'll see that the 9 counties that we cover, unlike Tech, our counties are not all rural. We actually have a pretty good mix, which brings about its own difficulties because we have both very highly populated counties, and then some that are very far out and very small school districts. So we have to really diversify our approach as we go into the schools to assist them. Next slide. So our current partnerships for schools, we have 24 active MOUs. We are present in every county that is in our catchment. We have another 13 that are pending. That means that we have a ways to go. There are about 52 more districts that we would like to partner with, that we have conversations going on with. And so we'll be looking in the near future to have active relationships with all of them. Next slide, please. In terms of what that means for covered lives, we talked about how the number of districts doesn't always directly reflect your number of lives. We're 62% through the 400,000+ students that are across the districts that we cover for our TCHAT program. And considering that we started in March of 2021, we've made tremendous progress. We anticipate and are very hopeful that we will be able to cover those remaining students by the end of 2023. Of course, that depends on our collaborative effort with the districts. So far, we have been very successful with our districts. Our teams go out and round with our districts at the beginning of each school year. We do reorient them to services, as well as find out if there's any educational opportunities that we can fill for their staff or their teams as we prepare to enter the next school year. Next slide, please. Within the week of the MOU being agreed to by the district and by our hospital system, we offer an onboarding for that school district. So this is a quick process. We have full support of our executive teams at the hospital and at UNT. And so our MOU process has been smooth as smooth as humanly possible. I'm sure you all dread as much as most people working with the attorneys to get all the paperwork right. But we've done a really good job of making that a quick process. We send out our project coordinator, clinical supervisor, our case managers, therapists, and sometimes the manager to do that onboarding for the district. During that onboarding, we do active training. We also answer any questions. We give contact information. We meet with everyone that the district permits us to meet with, including those that will be the designated individuals to send us referrals. Our therapists physically visit each school that's enrolled, that are willing to have us on site. There are some schools that security measures won't permit us to actually visit, but if permitted, we go out and we visit each of those schools. And our project coordinator, as I mentioned, will continue to do outreach at the beginning of each school year to reorient and provide support to any districts. If during that reorientation, we find that there is an education need, there is perhaps a consultative need or anything like that, we will match them with the appropriate clinician, provider, or whomever may be necessary to meet that need. We also attend almost all of the back to school events that we can as we prepare for new school years so that we're present. We have found that the schools have a heavy burden of identification. and they do a great job of doing that. We also want to be an integral partner with the families. And so attending those back to school events gives us an opportunity to also talk to the family and educate them about what resources may be available, as well as educating the actual school staff and team members and teachers. We found that the collaboration between the family, the school, and the care provider is integral to the success, and it allows everyone to operate with the same information. So that family connection is a very important part of our programming, and our case managers are integral to keeping those links connected. Next slide, please. So technology, as you know, the TCHAT program is virtual. And so in some of our districts, we do run into the limitations of technology. The great news with our funding and our project is that we have been able to purchase iPads for students to use for the purposes of accessing their appointments. Some students are doing their therapy sessions during the school day. Some are doing them at home. If they're done during the school day, then we partner with the school about making sure they have the space. We send our IT people out to make sure that the iPads work and that everything is working. Currently, we have about 50 deployed. As I said, in some of our more rural areas, connectivity is an issue. The internet is just not as stable. And in those cases, we have also deployed hotspots to assist with that. Our referral process is pretty smooth at this point. The designated individual for most school systems is the school counselor, but we have some smaller districts where it may actually be the principal. It just depends on the preference of that ISD. But the referrals are put in through our trade system. I've seen some of you comment about TCHAT, so you're probably familiar with our trade system. Those referrals are reviewed by our clinical supervisor and our provider. By provider, I mean our psychiatrist. And they are looking at that referral to make sure that that TCHAT is the right spot. And we have identified in some cases a student actually needs an escalation in care. And in that case, we immediately contact the school and work through that. But for the most part, those referrals will be scheduled, and we will work the process of getting consent signed and getting those students into care. If for any reason that student is not a fit, we're not just turning that referral away. The clinical supervisor and our case managers take over at that point to make sure that the school has the appropriate resources to get what that student actually needs. In some cases, our case managers will follow that case to connect them to an outside service to make sure that that need is met. Next slide. So our appointments, once the family submits the consents, again, all electronic, we can do all electronic consents. Once that is done, Monday through Friday during the working hours of the program, we can often get that student in within 48 hours. We still have capacity to do that right now. And we're trying to keep our hiring paced with our expansion so that we maintain capacity to quickly get students into care. Our first session is structured with an actual therapist, and our therapists are licensed professional counselors or social workers who are trained in therapy, and a provider. That provider could be a psychiatrist or an advanced practice practitioner who is specific to behavioral health. That initial session will be the full intake assessment and determining the appropriate treatment planning with the family and what needs to happen. The next element of our program that is a little bit different from what you might see in others is there is an actual treatment team meeting where there's a collaboration between the provider as well as the assigned case managers to determine next steps and needs for the student. And that determines how closely that case manager will follow that family. If it's identified that that family also has food insecurity, housing insecurity, clothing needs, or there's going to be a complex discharge, or that student is prescribed medication as part of their treatment planning, they will automatically get a case manager day one who will begin to follow that family on a cadence based on the needs of that student. Next slide, please. So you may be wondering what we're seeing in North Texas right now. We are seeing a lot of the things all of you are seeing. We're seeing an increase in anxiety. We are seeing increases in trauma issues and depression. We do have some suicidal ideation that's passive. grief. A lot of the students that we are getting right now are having difficulty finding an adult that they feel comfortable talking to. So a lot of the clinical intervention that we're doing has not only to do with coping skills, but also to do with fostering good communication amongst that family and identifying ways that we can help to support that. Next slide, please. So if you're thinking like, what does our population look like? On the screen here, you see a distribution of our patients by age. Right now, we're seeing mostly female students in our programs, and that seems to be trending higher as we continue to end this year. So we will see where that goes. Our age distribution, at first we were seeing mostly students between the ages of 13 and 17, but those ages are starting to decrease a little bit. So we're watching those trends to see what that means for the way that we train our therapists and how we move forward. Next slide, please. As you can see, as I stated, we started our program in March 2021. We have increased exponentially in terms of the utilization of the program, and that is only going up. We are receiving hundreds of referrals a month at this point, and I don't anticipate that to slow down as we continue expansion. Next slide, please. So in terms of our completed appointments, the thing to remember is there's a lot of families have questions about medication, the implications of prescribing medications to their students, and a fear that behavioral health means they're going to get meds. When we look at the complete distribution of our appointments, only 10% of our students come to us and actually need to have ongoing medication management. 90% of the students referred to us need a therapeutic intervention. And so being able to share that and track that with families has alleviated a lot of concern about the utilization of meds to treat behavioral health needs. Next slide. So it doesn't matter if we schedule all these appointments and nobody comes, right? So right now, our completed appointments are sitting around 93%. A lot of our low no-show rate, if you are familiar with the industry, no-show rates typically trend around 25%. A lot of our no-show rate reduction has to do with that connection with case management at the beginning and the continued contact with the families. Next slide, please. So I wanted to give you a distribution of our therapy versus medication management. Both of those no-show rates are low. Students that are enrolled in the program, families that become active with us, they show up to their appointments, and we do what we can to make that possible for them by having that student do sessions at school. Sometimes they do those sessions at home with the family picks them up from school, but we do whatever we can to make sure that they can attend that appointment and stay in contact with them. Next slide. So our discharge distribution is very high in Tarrant County. A lot of the discharges that we have end up going to a community partner. We don't specifically like create a relationship where you have to go to this agency or you have to go to that agency. It really is about identifying where does that student live? What is the verified resource in that region? Can we get the appointment? If we can't get the appointment, then we're going to stay with that child until that appointment is available. If we need to look at a different alternative, then we're going to do that. But we have a very diverse blend of resources that are available to families. And then we have students that after their sessions with us don't need ongoing care. One of the questions I often get asked is about re-referrals. We do get students that come back, but the percentages are very low there. And oftentimes it is for a new presenting problem. Next slide, please. So one of the things you've heard me say is we have these rural counties where resources may be slim. And if we have a child on medication management that needs that medication continued, one of the things that we do is partner with our CPAN program, our Child Psychiatry Access Network program. That program provides free consultation to family medicine practitioners and pediatricians who may be seeing a child or adolescent in their office who needs medication management, but they need some help in managing that case. And so oftentimes, once we identify a child in one of those rural communities who has a PCP and they're going to need a discharge plan, we can get those providers linked up with CPAN to continue that support and expand the access, even in that community, to others, because it's not just available to that child, it becomes available to anyone that provider treats. And we've seen a lot of success with doing that as well. Next slide. So for the summer, we just heard earlier that engagement in the summer is so important. Our therapists actually have done some specific training in DBT and trauma-informed CBT and a multitude of other modalities for short-term intervention and sometimes longer-term intervention. And so we have planned psychoeducational groups for the summer. In addition to the educational groups and the therapy groups that the students can go to, we've partnered group activities for parents to learn about what's going on with their students. And so this last summer was the first summer that we were able to offer that. We're currently in the planning phases for next summer. And so we expect that effort to grow. Next slide. And just to give you some context to some of the feedback, I won't read this to you, but the general consent is that our community has been very pleased with the efforts of TCHAT, what we've been able to do in the schools that are connected with us. And word of mouth has been our best advertisement. With schools talking to each other and kind of pointing out how much of a benefit the program is. And so we're excited to move forward and very, very enthusiastic about the future. Thank you.
Thank you so much, Tanisha. I just want to thank every single one of these panelists. They are doing such great work across the various regions of our state. And we have lots of Q&A. I hope that we can get those answered. Our time is going to be up very soon, but some of those I know Dorothy has answered, I've answered, and Jeff, some of them have to do with YAM. I want everyone to know that for those of you who have asked questions about where TCHAT is available or where you can get the Youth Aware of Mental Health in your region, I did post the information about the health-related institutions that are providing the Youth Aware of Mental Health. And also, though, if any of you have questions, please email the presenters on the panel who can talk with you specifically. Like I know, Jeff, you have some questions about ECHO and some of the supports you're providing. And Dorothy, you had some about communities and schools. And Tanisha, I think there's some questions as well about, regions and which counties and school districts, et cetera, are available to, receive some of the services. So we will do our best to address those questions and answers. And I just want to thank each one of you, Dorothy, Tanisha, and Jeff. You guys knocked it out of the ballpark, and the work you're doing is fantastic. So thank you so much.
Thank you, Luann. We appreciate this opportunity.
Yes, thank you all.
Yes, thank you.
Thank you, Luann, Jeff, Dorothy, and Tanisha for that incredibly informative presentation and sharing of resources. One of the overarching themes of the summit is strong partnerships, and we appreciate that you elevated that in sharing your wonderful programs. Questions that weren't answered aloud will be addressed in the Q&A feature, and the presentation and resources will be housed in the shared box and on the schoolmentalhealthtx.org website.